Module 2, CPT Coding Expanded. A lot of this material you will remember from Module 1, however, due to the nature and difficulty of CPT coding, it will be reviewed again. In this module, we will reevaluate what CPT coding is, the evaluation and management aspect, key components of the office visit, and lastly, case studies. If you'll remember from Module 1, CPT codes allow for reimbursement of a service that is performed at the clinic. These services are based on a value scale that is based on work done, expense, liability, insurance, and geographic location. In order to bill for a certain CPT code, documentation must reflect the service performed. The CPT code is a 5-digit number that is attached to an action such as the office visit, counseling for smoking cessation, certain screening tools, laboratory testing, and more. Remember that you cannot bill for labs that were not performed in your office. If you are having to send out a CBC, then you cannot bill for it. If you are having to refer a patient for an x-ray, then you cannot bill for performance of the x-ray. However, if you run a urinalysis in the office, you can bill for that. If you have the capability to run a CBC in the office, then you can bill for that too. In order to bill for a CPT code, the interaction must be face-to-face with the provider and patient. You have to associate each CPT code with an ICD-10 code. For example, you would like to run a CBC, then you must have a diagnosis code with it. You could use the ICD-10 code for hypertension, which is I-10, and then order a CBC, or you could attach E11.9, which is type 2 diabetes, and run an A1C. The level of service for your billing is determined by the extent and complexity of the key components. In order to bill for something, you must document it. For example, you cannot bill for smoking cessation counseling if you do not document that you counseled the patient on smoking cessation. If you remember from Module 1, we discussed 4 key components of office visit coding. These include the chief complaint, history, exam, medical decision-making. The following information should look very familiar to you. We will be reviewing CPT codes yet again for clarification. The chief complaint is the statement for why the patient has presented to the clinic. You should chart this in the patient's words and make sure that it is documented appropriately. The next component is the history. This includes a variety of aspects of the patient's medical, social, and personal history. The first to note is the history of presenting illness. This is typically when you would use your old carts and search for the information that will point you in the direction of the patient's concern. The different office visit levels are determined by the number of elements you reviewed with this patient. Sometimes the old carts method is not the best way to review a patient's history of presenting illness. As you can see in the detailed section, this addresses chronic diseases that the patient currently has. For example, an expanded problem-focused exam would focus more on old carts to determine the patient's recent upper respiratory symptoms, but a detailed exam would focus more on questions about the patient's chronic condition, like how they are taking their medications, any concerns they might have, and of course any physical or mental symptoms they would be experiencing. The next component to the patient's history is the past medical, surgical, family, social, and potentially personal history of the patient. During a nurse visit for a vaccine, it would not be pertinent to ask about family history, so this would be a 99212 code. However, if you are to perform a detailed or comprehensive exam, then these aspects of the patient's history would be pertinent. Allergies and history of tobacco use are almost always pertinent when obtaining a history on a patient, but if the patient presents for strep throat, it might not be pertinent to ask about family history. Likewise, if this patient reports chest pain, then a family history would be pertinent. This is where it is important to understand your disease processes and to understand the importance of the different components of the history. If you're having a difficult time determining what level you should code based on what you have done, charts like these are an excellent example to benefit your practice. This chart and others like it will be found later in Module 2 for you to have access. The next component of the history is a review of systems. This is an overview of the patient's symptoms. It is a subjective report from the patient and is useful to narrow down what differential diagnosis you have for the patient. Remember that MAs and nurses can perform the ROS, but you need to review it for accuracy. This is an essential component of your patient encounter, so make sure to review it thoroughly as it will help guide your diagnosis. This chart will help you as you begin your CPT coding process. The review of systems focuses on systems that you have addressed. Here's a summary of the review of the history aspect of charting that we just went over. You will be provided with resources to print, copy, scan, and bring with you later in Module 2. The next part of the 4 key components is the physical exam. The way you establish your level of coding with the exam is through the number of elements you addressed and not the number of systems you addressed. It is a problem-focused exam if you only examined a limited body area or organ system. The expanded problem focus must have the affected body area assessed plus other symptomatic organs. The detailed exam needs an extended exam of the affected organ plus other symptomatic body parts. The comprehensive exam requires at least 9 body systems to be examined with at least 2 elements in each system. These elements can be confusing, so using a chart like this one as you start the coding process will assist you in deciding what type of exam you performed. As we reviewed in Module 1, let us review the difference between the elements again. A person comes in with cold symptoms, so you briefly examine their ears, nose, mouth, neck, heart, and lungs. You have examined multiple body systems, but you have examined only 10 elements in the systems total, making this an expanded problem-focused exam. To be a detailed exam, you would need more information, but to be a problem-focused exam, you would need less information. Now looking at the second example, you have a patient come in with fatigue. The vague nature of fatigue as a chief complaint warrants a thorough assessment of many body systems, as this could be a symptom related to the endocrine system, the circulatory system, the respiratory system, or even the neurological system. So a large array of systems need to be reviewed. In this instance, you reviewed 9 body systems and looked at 2 different elements in each of these systems. For example, you examined the neck, but looked at both the thyroid and the lymph nodes. You examined the respiratory system, but you looked at for lung sounds, but also the AP diameter. So you've assessed multiple body systems, but also multiple aspects of each of these body systems. Moving on to the medical decision-making component of office visit coding, there are several diagnosis and management options. The problem you diagnose could be self-limiting, like a viral infection, or an established problem that is stable, like high blood pressure. You could have an established problem that is getting worse, such as a patient with type 2 diabetes whose A1C went from 9% 3 months ago to 12% this visit. You could have a patient with a new problem that needs no additional workup, such as strep throat, or you could have a patient who comes in with a mass in their breast and they're in need of a mammogram. Other things to consider in the medical decision-making process is if you had to do anything else for this patient, such as order and review labs, perform an x-ray, or order other diagnostics tests such as like an ultrasound or a CT scan. You must also consider the risk of the diagnosis. The diagnosis of an upper respiratory infection is not as much risk as a diagnosis of COPD because of the complexity of treatment. Using this chart to assist you will be very helpful. As you can see, there are many different components to the medical decision-making process, and having a chart like this will definitely assist you as you begin the process and learn what aspects make up each level of coding. Here's that chart continued, and remember you'll have this later on in Module 2. This is a summary of the medical decision-making process. It shows how the different levels are chosen based on the number of management options, the complexity of the data, and the risk for complication. The hard part now you just have to figure out how to pull it all together. Remember how in Module 1 we mentioned that new patient and established patient coding are different? See how the levels of care have different numbers? These basically mean the same thing as an established visit would, but the coding is different due to the increased time spent with new patients. New patient coding follows the same rules and is evaluated based on history, exam, and medical decision making, but the numbers are different for the final coding process, so make sure to pay close attention to this. This is just a summary of the established office visit coding. The majority of the time you will be using one of these codes, but always remember if it is a new patient or preventative visit, then these codes will be different. Time is a factor for coding only when greater than 50% of the time is spent in the visit for counseling. So if the provider counsels the patient on smoking cessation for 20 minutes out of a 30-minute visit, then they would be able to code based on time instead of complexity, risk, and exam type. This provider would also be able to use the CPT code to bill for smoking cessation counseling. If the provider decides to bill based on the time spent in the room counseling the patient, they need to make sure that there's adequate documentation on the time spent and the counseling done with the patient in order to bill based on time. Let's work on some case studies. You saw case 1 and 2 in Module 1, but now we'll look at these from a different viewpoint. You have an established patient who is an 8-year-old female who presents to the clinic today with a sore throat for 2 days. Her mother says that she began complaining of a sore throat 2 days ago. She developed a fever last night with a temp of 102. Her mother reports that Tylenol helped decrease her temperature to 100, and she has not had any Tylenol this morning. She reports that her daughter has also been complaining that her stomach hurts. She's been nauseous since last night, but has not vomited. She does not have a headache, rash, swollen lymph nodes, diarrhea, cough, runny nose, or muscle aches. She's allergic to latex and tree pollen, and she's currently taking Allegra. Her ROS, no headaches, runny nose, swollen lymph nodes, but she reports a sore throat, no cough, reports abdominal pain, and nausea. Her vital signs: temp 101.4, O2 98%, heart rate 98, respiratory rate 18, blood pressure 90/17. She is 4 foot 4 inches and 52 pounds, which is an ideal weight for her. Okay, so she's a white female who appears to be in no acute distress. Her tympanic membranes are pearly gray and intact. She has pink mucosa with clear drainage. Tonsils are 2+, erythematous, and with white to yellow exudate. Her submandibular lymph nodes are swollen and tender upon palpation. Lungs are clear. Heart rate is regular, and rhythm is regular. Bowel sounds are present and active. No masses noted. The last time we decided to run a strep test based on this patient's clinical presentation. Same thing in this case. Test was positive. Now remember, for screenings like this, that you must see the control line, otherwise the test is not accurate. We diagnosed the patient with strep throat. So now let's look at what all we have done to determine the CPT code for this patient visit. Back at our history to determine what we have done. So we reviewed allergies in case we need to give her any medications, and we reviewed her medications. We reviewed HEENT, respiratory, and GI systems. If complaint is present, we assessed onset, alleviating factors, and associated symptoms, making this a brief HPI. Our ROS focused on HEENT, respiratory, and GI systems, so that would be considered a detailed ROS. But we did not review any of the past medical history except for allergies and current medications. Here's our physical exam again. We looked at the general: ears, nose, throat, lymph nodes, lungs, heart, bowel sounds, abdominal tenderness, and skin. Exam, we assessed 10 different elements for several different systems. This places us in the expanded problem focus section. Determine the medical decision-making process. The number of options was limited, the complexity of the data was low, and the risk of complication is low. So this puts this encounter into the low complexity category. Based on the history, the exam, and the medical decision-making process, this would be coded as a 99213, or expanded problem-focused patient encounter. Here's a pocket guide that can be taken with you to clinical to assist in your decision-making process. You will be given this later in Module 2 to assist in your clinical setting. And 99213 plus the CPT code for the rapid strep test that was performed in the office. Moving on to case study 2, this is a new patient. He's a 52-year-old male who works in landscaping, and he came into the clinic reporting that he got into poison ivy 2 days ago. He reports that he was exposed to poison ivy. He noticed the rash began to form yesterday on his hands, and now it has spread and become much worse. It is now located on both hands and forearms. He reports that he has had a reaction in the past that was similar to this instance. He has been using hydrocortisone 1%, but it has not helped, and he is itching. Patient denies having the rash anywhere else. So he has a history of poison ivy allergy, allergies to penicillin, and he is currently using hydrocortisone 1% cream, but nothing else. His review of systems shows no runny nose, no change in vision, no sore throat, no wheezing or coughing, no shortness of breath, palpitations, chest tightness. He has a red, weeping, itchy rash on bilateral forearms and hands. His vital signs are stable. BMI, he is obese. So we have a 52-year-old white male who appears to be in no acute distress. His conjunctiva are pink. Nasal mucosa is pink without drainage. Pharynx is pink without edema, no tenderness or swelling of lymph nodes. Regular rate and rhythm of his heart. Lungs are clear to auscultation. Skin, he does, of his bilateral hands and forearms are covered in numerous vesicular lesions on an erythematous base. No weeping is present and no open vesicles noted. Remember this image in your diagnosis? Code for that. We had a chief complaint, a brief HPI, and a problem pertinent review of systems. In the exam, we assessed 8 different elements, making this an expanded problem-focused assessment. As evaluation and management go, this is straightforward. There are minimal diagnostic options, little complexity, and at minimal risk for complication. This was a new patient, so he needs the new patient coding for 99202. The codes for this patient encounter are 99202 for the new patient office visit and a 94760 for the pulse oximetry reading. Okay, so case study 3, we have an established patient who is a 32-year-old female who comes in with complaints of fatigue. She says the fatigue began about 2 months ago. She's not currently taking any medications, and she's not had any recent illnesses or surgeries. She reports that she'll go to bed at 9 and wake up at 6 and still feel tired. She reports that she only drinks coffee in the morning. She turns her TV off 1 hour before bed. No reports of fever, headache, blurred vision, edema, shortness of breath, palpitations, snoring, or diarrhea. Patient reports fatigue, a recent weight gain of 15 pounds, hair loss, dry skin, and constipation. Patient reports that for the past 2 months her periods have been regular but heavy. Denies exposure to TB, recent foreign travel, or spending time in the woods. She has no known drug allergies, not on any medications. She is a G1P1 with a C-section in 2015 with no other history. No tobacco, drug, or alcohol use. Her mother has a history of hypothyroid. Her father has a history of diabetes, and her maternal grandmother has a history of stroke. She had her pap smear back in 2016, and last time she had laboratory work was 2016. She reports fatigue, weight gain, but denies fever. No headaches, blurred vision, sore throat, runny nose. She reports hair loss. No edema or palpitations. No shortness of breath or reports of snoring. No reports of diarrhea. She reports constipation, though. She reports dry skin. No swollen or painful joints. No neck or back pain. She reports irregular, heavy periods. And no thoughts to harm herself or others. So we're going to use the PHQ-2 scale, the Epworth Sleepiness Scale, and the Partner Violence Screen. Her vital signs are all stable. She is a little bit overweight, but she's not in any pain. Alright, so we have a 32-year-old African-American female who appears to be in no acute distress. She does have thinning hair. Her conjunctiva are pink. Her nasal mucosa is pink without drainage. Her pharynx is pink. No tenderness or swelling of the lymph nodes. Thyroid is not palpable, and no bruit is noted. She has a regular rate and rhythm with no edema. Her lungs are clear to auscultation. Her bowel sounds are hypoactive. There's no rashes or lesions on her, but she does have some generalized dryness. She has full range of motion of upper and lower extremities. She's alert and oriented ×3, and mood is appropriate for situation. So we are going to get these labs on her. A urinalysis, a CBC with diff, a CMP, TSH, T4, hemoglobin A1C, and a vitamin D on her. Her diagnosis is fatigue because we don't have anything definitive right now. And you can code the patient's symptoms at this point until you get a definitive diagnosis. Based on the history, this is a detailed exam. The chief complaint was present, there was an extended HPI, the review of systems was extended, and the past medical history, family history, social history was pertinent. Systems reviewed, but not more than 9, so this would fall under a detailed exam. Complexity in this case is moderate, as there are many potential diagnoses with different management options. The complexity of data is moderate, and the risk is moderate. This would be considered a 99214. Very rarely are you ever going to code a 99215. Here's your pocket guide. Office visit coding is going to be a 99214. The UA is a 81001. Venipuncture is a 36415, and pulse oximetry is a 94760. We did not code the other labs that we ordered. This is because we sent these labs off to be performed, and so the lab will code them for us. Thank you.